Immunotherapy has an important role in all aspects of lung cancer, driver or non-driver disease. Certainly in the patients with no known driver, immunotherapy offers hope that we haven't seen in many years. The fact that here we can use this drug in a certain percentage of frontline therapies that are PD-L1 positive, pretty much everyone is now getting it as a second-line therapy, one of the drugs. Where we're seeing activity, 20+% response rates, and certainly there are populations that benefit more. They're the patients who are living disease-free 5-6 years. We need to figure out what is it about those patients, and then what is it about those patients who receive immunotherapy for 6 weeks and then they're already progressing. That's part of our research at places like Yale. We have a lung spore grant that's looking at that, trying to figure that out. There's also a big role for immunotherapy in patients with driver mutations because, I've treated patients, for example, with EGFR inhibitors since the first clinical trials we did with gefitinib. We called it ZD1839 back then in 1998, and no one's cured because patients become resistant to these targeted therapies. So you've got to think that there's going to be a role for these immunotherapies, in the patients who become resistant. It's been a bit challenging to sort of incorporate them in because of combined toxicities of small molecule EGFR inhibitors, especially the newest generation drugs, and these antibodies. But those trials are ongoing, and I think now that we understand a little bit better how to manage the toxicities, we will see that in place. So there's a role for immunotherapy across the whole spectrum of advanced non-small cell lung cancer. PD-L1 expression is used in a number of ways. Certainly, if you're going to use an agent that targets PD-1 or PD-L1 up front, in the untreated lung cancer patient, one would want to use a selected population that's PD-L1 positive. That's quite clear based on Keynote-24, showing that in the patients that are PD-L1 positive at 50%, there's a survival advantage, hazard ratio 0.5, for PFS benefit 0.5, hazard ratio 0.6 for using pembrolizumab. Interestingly, with nivolumab using a cutoff much lower, that wasn't seen. So I think PD-L1 clearly has a role in choosing frontline. As far as using the drug in the second line, given that PD-L1 is a dynamic marker, there is some heterogeneity, that's a little less clear. Certainly in the Keynote-10 trial, on which I was the PI, we actually did see that between the 1% and the 50% cutoffs, there was a clear improvement in the benefit of the pembrolizumab versus docetaxel. So certainly, you can use the PD-L1 to tell you who's more likely to benefit. But from the trials with nivolumab and atezolizumab, that either one looked at the biomarker atezolizumab or the nivolumab that looked at it more informally, there did appear to be benefit in the patients who were PD-L1 negative. I think that there clearly are patients who would benefit who are PD-L1 negative, either because it's a false negative or because there are other mechanisms at play that we don't understand yet, whether it be mutational load, neoantigen load, maybe gene signatures, and meaning what's going on in the immune microenvironment, how many T cells, what character of T cells. So it's still a bit of a moving target. So my feeling is one can use these drugs in all settings.